Uh, Good evening, everyone. Today I wanted to share this case with you. This because of its grave importance in our daily practice right now. Everyone should be aware of that case and aware how to diagnose it correctly. This case was of a young female patient presented about maybe 10 days ago with some fever, cough, shortness of breath, and she was diagnosed positive. She tested positive for the coronavirus, the COVID 19. Uh, Over the course of the last 10 days, her condition worsened acutely and she became severely dyspneic, and chest CT without contrast was ordered for her. First of all, I want you all to take a quick look on the chest CT findings shown here. This is the lung window. It was a CT without contrast. You can obviously notice the motion artifact due to the rapid breathing. The patient was dyspneic and was unable to hold breath and even a little bit subconscious, drowsy. So this first thing you notice is the breathing of the patient is heavy, fast, and she's dyspneic. Second of all, the main or the primary abnormality that you look for in this CT scan, or that is obvious in the CT scan, is the diffuse ground glass and airspace opacification. Notice that it has no particular lobe involvement. It is here it was diffuse all over the lung, involving both lungs bilaterally. Some areas are like, for example, here and here are of ground glass density that you can see the lung parenchyma through the opacified parts, and some parts like for example here you can see there is an air, and here there is an air ground there is a sorry an airspace opacification consistent with pneumonia. Even some bronchograms are seen here and there, like here and here you can see some faint air bronchograms indicating pneumonia. The thing is, if you look carefully, you can notice there is a diffuse bilateral interlobular septal thickening that you can see between the lobes, like here and here. This pattern, between the patchy ground glass areas, there is interlobular septal thickening. With the patches are relatively, let's say, partially well defined. This indicates what's called a crazy paving pattern. You can see it obviously in these parts. You can see that this lobule is affected, and this lobule is affected, this lobule is affected. It is very well defined as opposite to what you expect of an ill-defined pattern. No, it is a well-defined pattern of diffuse ground glass opacification with airspace opacification and some interlobular septal thickening causing a bilateral ground glass opacities. Also, something else to be noticed, that it is mainly in the perihilar region and it radiates peripherally. You can see it start, or it's more dense in the perihilar region, and it goes into the lateral parts of both lungs, like here and here. It's denser at the perihilar region and relatively less severe in the outer parts of the lung. Also, you can notice that the main lobes that are most severely affected are the lower lobes bilateral. You can see this, the upper lobe and the middle lobe on the right side, for example, and even in the lingular part of the left upper lobe is relatively not severely involved, or less severely involved. The main involvement is in the lower lobes bilaterally, and that's probably because the lower lobes are less well ventilated compared to the upper lobe. The upper lobes are usually more ventilated or hyperventilated in this patient who is bedridden for the last few days. The interesting things that you have to pay attention to is not the what's there, it's what's missing. For example, if we go to the soft tissue window, you can see that despite all of the abnormalities that I described before, there is no pleural effusion at all. So, lack of pleural effusion is suspicious for this kind of infection, the viral pneumonitis that occurs with the COVID-19 infection. And you can notice that the lymph nodes are just few small, maybe here, tiny lymph nodes, not the way that you would expect of from this severe infection. If this was a bacterial infection, believe me, there will be bilateral pleural effusion, and there will be some significant lymphadenopathy as compared to this patient here with just a few tiny, probably insignificant lymphadenopathy. So there is no pleural effusion, and there is no lymphadenopathy. The heart size is relatively normal. There is no cardiac abnormality. Consider this is a young patient with no previous history of any cardiac disease. So keep in mind the following things to look for in COVID pneumonia. The patchy ground glass opacities bilaterally, almost symmetrical, maybe one side more than the other. There is no pleural effusion bilaterally, no significant lymphadenopathy. The patchy ground glass opacities is interspersed with areas of airspace opacification causing and interlobular septal thickening causing crazy paving pattern, and there is no pneumothorax bilaterally, no signs of pneumothorax, and the distribution is mainly from radiating from perihilar into the peripheral aspect of both lungs, and it's more in the less well ventilated areas of the lungs, that is the lower lobes bilaterally. And even you can see that the lung apices are relatively spared because they are well ventilated. The upper lobes are usually less severely affected because they are well ventilated. So of course there is no bony abnormality because it has nothing to do with the viral pneumonitis. And this if you have these findings in any patient, of course this is a severe or progressive case of viral pneumonia. We should look for similar changes in I hope less severely affected patients. If you have any case like that, please contact your local authority for proper testing and exclusion of coronavirus infection. And I hope you will all be good and fine, and to be careful, use protection as much as you can, and be careful in dealing with the patients because it is a contagious virus, and we want to go through this problem, I hope, in a nice, healthy way without any mortalities. Thank you very much. This is Dr. Ahmed D. Abdulwahab.